Hello, everyone. My name is John Davis at Mayo Clinic in Rochester, Minnesota. I'm the associate editor for the Journal of Rheumatology. Welcome to my interview with Dr. Khidir and Dr. Bender Helm-van Mill about their article entitled Identifying Resolution of Clinically Suspect Arthralgia, a Step Toward Understanding Spontaneous Reversal of an At-Risk Stage of Rheumatoid Arthritis. That was published in the January 2026 edition. Congratulations, Dr. Kadir and Dr. Bender Helm-van Mill on this important study. To begin, could you please explain how you define clinically suspect arthralgia in your research and the criteria that are used to identify patients at this stage? I know there are criteria that are published. Not all my author or the audience may be aware of those. So we can start there. Thank you.
Well, thank you for this question. Thank you also for the invitation to be here today together with the PhD student Sarah. Thank you for this question. So actually the aim why we defined clinically suspect arthralgia, so CSA actually, is to discriminate arthralgia at risk for from a broader range of musculoskeletal symptoms. Um, and actually, there are two ways to define CSA. You can either do this in the clinic as a rheumatologist based on your expertise, and you actually can also use the Euler criteria. In our research, we used both definitions, and actually the results were similar what we did. And I think to explain it a bit more, so I think as a rheumatologist, you will see patients, or you can see patients that if you hear the story, it looks like rheumatoid arthritis, the morning stiffness, pain, and so on. But if you then do the physical examination, there are no swollen joints. And then we can recognize them as having a clinically suspect arthralgia. And we have observed that then you have a high sensitivity and specificity compared to a broader range of musculoskeletal symptoms to really separate this group and define this group. Actually, but we do know that for research, you may find that an expertise-based definition is very useful for daily practice, but it may not be so well helpful perhaps for research. And therefore, you can also use the Euler definition of CSA on top of your clinical expertise. This definition has been published a while ago. It's consisting of 7 items, and if you have 3 out of these 7, then actually you can be considered positive for the Euler definition. So this is more for studies to get the more homogeneous groups of patients, and perhaps you can compare this with rheumatoid arthritis. So in daily practice, you use your clinical expertise to diagnose RA. You don't need criteria for that. But if you then do research, you often want to do the criteria, to the criteria, and then you do them on top of your clinical expertise. So you can do this the same with the definition of CSA. But for this research, it did not really matter if we took only the patients that have CSA according to the rheumatologist, or the large majority of them that also filled this Euler definition.
Yeah, thank you, Helm-van Mill. So that's really great. I think it certainly as a clinician, it rings true with me. I see these patients in clinic, and you can't find clinical synovitis, but it sure sounds like they have an inflammatory syndrome, and what to do with those patients is something that we need to define even better. So I appreciate the work that you're doing and your leadership in this space. I want to get now to the concept of that's in your title of reversal or resolution of the at-risk stage, which obviously is central to this work that we're talking about today. And I'm aware of some of this field, but again, for maybe the audience, so I think the idea is that the patients with their joint pain, it's getting better, right? And some of them, maybe not all patients progress. But tell us about the background of why you've been focused on studying that in the study here.
Yes,
That's an interesting question.
definitely.
And I would
Oh,
like to give the
yeah.
word to Sarah, indeed, to this
Oh, yeah.
question, if you agree. Yeah.
Thank you.
Thank you. Yes, definitely. So we know that a lot of studies in the at-risk stage of RA have focused on those who progress to RA. And in this study, we focus specifically on those who did not progress to RA. So these non-progressors is where we focused on. And this group consists of approximately 70% of the at-risk population. And we know that a subset of these patients also have resolution of symptoms. And by saying this, it is as if they go back to a healthy situation. And this phenomenon of going back to a healthy situation is what we call reversal of the at-risk stage. And the used assessments or the definitions that we use to assess, to study in our research is what we call resolution.
Very good. Well, I think it makes perfect sense. It's good to discuss it. Maybe we can get into the nitty-gritty of the study now. Tell us about, the objectives of what you're trying to accomplish for this particular study.
Yes, so we knew that there are patients in the at-risk stage who develop resolution of symptoms, but still many questions remained, and this population had remained largely unexplored. So the main question that we had is how should we define this reversal of the at-risk stage? And so our aim was to study several definitions of this reversal, and our aim was thus to derive a good definition for this phenomenon. And this would then be a step towards understanding the processes that are involved in this phenomenon. And how did we do that? We studied two patient-reported measures on one hand, and on the other hand, we studied one rheumatologist-reported measure. And we compared these two, and our aim was to arrive at the best definition with the highest face validity for that. And after that, we continued our research by validating the use definition, by also studying the association of the definition with also long-term outcomes. And in our study, that was the course of subclinical joint inflammation that I will also discuss later on in this interview, but also the course of functional disabilities.
Mm-hmm. Yeah, no, that's an interesting, certainly phenomenon. These patients that don't have defined disease can certainly have functional disabilities and a lot of pain and other symptoms. So it's not necessarily an innocuous state, although obviously many of the patients get better or they reverse course, as you've described here. Wanted to talk about, I've been aware of the resources that you've had at the Leiden CSA court, and that you also, I think, have studied in the Treat Earlier trial. That was a trial of methotrexate at this at-risk population. Maybe for the audience, describe the value of these resources that you've been studying and sort of what they are and how they've allowed you to work on studies such as the one we're doing today.
Yes, thank you, definitely. So the CSA cohort in Leiden is an inception cohort that is running since 2012. And the inclusion criteria is as Professor van der Helm just described. And the follow-up visits are regularly and consists of extensive assessment of physical examination, but also laboratory testing, patient-reported outcomes, and also MRI. And the Treat Earlier is a trial that consists of CSA patients who also have subclinical joint inflammation on MRI. And for our study that we discuss now, we use the placebo arm of the Treat Earlier study. And the innovation of these cohorts, we think lie in two aspects mainly, and that one is the inclusion is based on the clinical phenotype. So no additional testing was performed before the inclusion happened. So this means that we have both ECPA or antibody negative patients, but also antibody positive patients, but that this did not influence whether patients were included. And also the second thing is that so these patients were not treated with DMARDs. This means that you can study the natural course of the at-risk stage in detail.
Yeah, again, really fantastic studies that you all been doing there. I'm attracted to the approach of CSA in many ways, but importantly because of the antibody negative populations that otherwise are missed if we're focusing on ACPA positivity and recruiting. And I think the seronegative patients wind up being the patients I struggle with the most in the clinic by the time they get to us. They tend to be less responsive, it seems, and just in general. And there's always this uncertainty in the diagnosis. So kudos to you for really trying to tackle that aspect of this. Um, so moving on to the next question, and you've already alluded to this quite a bit, but you used a couple of definitions of CSA resolution, one being the patient, the other being a physician-based. Maybe kind of explain your approach of maybe why you looked at both of those definitions, and then how you went about doing that.
Yes. So we really wanted to study which definition would be the best. So that's why we started with studying patient-reported measures on the one hand, and the other hand, the rheumatologist-reported measure. So let's start with the patient-reported measure. At first, we started by focusing primarily on pain. So we studied pain resolution reported by the patient, and that meant that At the last visit, the patient reported a pain score of maximum 20. And this 20 was on a scale, on a numerical rating scale, ranging from 0 to 100. Later on, we also studied patient-reported resolution of pain and morning stiffness. So when both outcomes were maximum 20. That was for the patient-based. And then on the other hand, we had the rheumatologist-based. And that was a question that was asked to rheumatologists during follow-up with the question whether CSA is still present, yes or no. And if the rheumatologist had answered that the pain had gone or that the pain was not suspicious anymore to imminent RA, we considered that as resolution of CSA resolution according to the rheumatologist.
Yeah. And then the next, I think, concept that's important to talk about, Dr. Khidir, is the concept of subclinical inflammation, and obviously studying these patients with MRI and looking for findings there. Talk about that a bit more and how you use MRI in the study and what you were evaluating in terms of and what you were included in terms of subclinical inflammation.
Yes, indeed, subclinical joint inflammation, as the term already says, it is subclinically present. So what do we mean with that? So these patients don't have clinical arthritis at physical examination. However, if we perform an MRI of the hand and foot, then we see subclinical joint inflammation. And the MRI is scored on 3 types of inflammation, and that is synovitis, tenosynovitis, and osteitis. And the MRI was scored by 2 experienced readers according to the RAMRIS method. And the sum of these 3 components of inflammation quantifies the severity of subclinical joint inflammation.
Mm-hmm. Was there any, I maybe we'll get to the findings in a bit, but uh, in this population, I know in your previous studies, there's been a lot of tenosynovitis has been an important finding in these patients, right? And that certainly makes sense to a clinician and why you might not be able to detect that on physical examination. Um, and was that present in a lot of these patients that resolved, or was there any differences in the subclinical inflammation patterns in the patients that reversed versus the ones who progressed?
Yeah, so a very interesting question indeed. In our study, we looked at the total sum of subclinical joint inflammation. So we saw that these patients indeed have subclinical joint inflammation, and that also decreased over time in those who develop CSA resolution. But indeed, an interesting question of whether there was a difference between the types of inflammation. In our study, we did not study that, so we cannot answer with our data that we have now. But it would be very interesting to indeed study further.
Yeah, that's a nice suggestion, actually, John, because we also have seen that tenosynovitis is the most predictive one, actually. It seems to be the earliest phenomenon of the disease. So it's apparently, if you develop joint inflammation, it seems to start with tenosynovitis. So actually, it starts outside the joint. And we see that tenosynovitis is the most predictive. So you can then think that if you have tenosynovitis, you will not get a resolution. But yeah, Sarah, I think you cannot leave our group and you have to do more work because we don't know that yet. Yeah.
That's wonderful. Yeah, thank you. I agree. I think that would be an interesting question to as a follow-up for this. You probably have the resources to do it. I may have skipped ahead there a little bit, but I was just fascinated with thinking about that. So I'm going to give you opportunity to talk about for the audience the key findings of the study, and especially, and I know you'll compare the results between the physician and the patient-based definitions of CSA resolution.
Yeah, so again, we focus on those who did not develop RA and who had sufficient follow-up. So we had 505 patients, out of whom 71% developed CSA resolution according to the rheumatologist. On the other hand, you had 48% who had developed pain resolution according to their outcomes that they reported. So we wanted to study the overlap and discordance between these 2 groups. And we saw that 158 patients had CSA resolution according to the rheumatologist, but they did not report pain resolution. And the rheumatologist said in these patients that their pain was caused by had a different cause than imminent RA. And the other outcome was that we saw that 32 patients had resolution of pain, so no pain, but the rheumatologist said there's no CSA resolution. And in these patients, we saw that the rheumatologist said that there were still inflammatory symptoms such as morning stiffness. And based on these results, we said that CSA resolution, according to the rheumatologist, had the highest face validity. And that we validated by studying the course of subclinical joint inflammation and functional disabilities over time. And indeed, we saw that both of these outcomes improved over time. And interestingly, patients who had no CSA resolution, according to the rheumatologist, did not show decreasing subclinical joint inflammation, indicating that there may be still an inflammatory process going on. Another interesting thing that we saw was that numerically, patients who had CSA resolution were more often ECPA negative, but we also saw that there was a subgroup of patients who were ECPA positive. More specifically, 34 patients who were ECPA positive did not develop RA at the end of follow-up, and 20 out of these 34 developed CSA resolution. So although these numbers were smaller than the ECPA negative group, we concluded that CSA or reversal of the at-risk stage can happen in both groups. And to conclude my story is also that we saw that at baseline, these patients who would develop CSA resolution later on did not have lower levels of inflammations, but they had lower levels of reported pain, morning stiffness, and fatigue.
Okay. Yeah, it's especially fascinating because I think a lot of people might presume that if the aqua positive ones are the ones who wouldn't resolve, but it's good to see that in that population too, that it can it may not progress, and in fact it may subside or reverse course. I've participated in fewer studies like you have conducted, but I was a participant in the Stop RA study in the U.S. with recruiting people for and randomizing the hydroxychloroquine with Dr. Kevin Dean and colleagues, and it was fascinating to get the unblinding sometimes, right, and see which drug patients were getting. And sometimes you thought, oh, maybe they got better, and in fact they were randomized to placebo. So evidently it wasn't a treatment; it was just spontaneous, and I had that experience. I think the other thing that your work, I've done some research on this concept of discordance between patient and physician assessments of in at least established rheumatoid arthritis, and of course it's not always so easy, is it? And even in the Stop RS study, I had the experience of some patients that had, one I remember had very high titer ACPA, but had kind of almost like an inflammatory OA of the DIP joints, but really didn't have RA-like synovitis. And so she was eligible for the study. And in fact, I think that I'm trying to remember, but if she got study drug or not, but it's of course assessing causation and attributing what to what is can be challenging. But I think the approach you used here was quite appropriate. Wanted to kind of, I guess I was fascinated with thinking about the question of, right, what drives progression in the CSA patients and why might some of them not progress? And I think you had alluded to the idea in your paper in the discussion of that maybe it needs an additional hit that may trigger patients to go from an at-risk stage of CSA to clinically overt inflammatory arthritis and RA. And of course, it's fascinating to sort of think about the potential triggers. One obvious one that I thought of that I'll throw out there is, of course, viral infections or something could be a factor, or something in the environment. Maybe not. Some airborne trigger, with airborne exposures is something that we are interested in studying about and concept of RA, because we know the mucosal origins hypothesis, right, of RA development. But yeah, what are your thoughts? What are the other hits that we should be thinking about?
Yeah, very interesting question, actually. So actually, just perhaps a pivotal one. So now we change the subject a little bit from resolution, actually, from this stage to progression to RA. And I think in general, I think the development of RA can be separated in two risk phases. So you first have the phase without symptoms, and then thereafter a phase with symptoms, such as CSA or something else. And I think if you think about the risk factors for RA, I think most known risk factors actually seem to work or to act in the asymptomatic period. So for instance, smoking, it acts in promoting the development of autoantibodies, or for instance, epitope alleles, HLA and epitopes, the promote the progression of the autoimmune response, maturation of the autoimmune response, but it all happens mostly in the asymptomatic period when people are still at home and don't visit our clinics, actually. Also, obesity works in this asymptomatic period already. But we often in our clinic, we see the patients with arthralgia or CSA, so then they have the symptomatic risk stage, and we don't know much actually about risk factors acting in this symptomatic risk stage. With very recent studies from actually our group observed that there is one risk factor that promotes the CSA onset and progression to RA, which is actually work-related physical strain. So in this symptomatic period, people get subclinical joint inflammation and it can progress towards clinical disease. And we observe that patients with more mechanical strain, work-related strain, develop subclinical joint inflammation more often. And thereafter, they progress more often to clinically overt disease. So apparently, when you get local joint inflammation, your mechanical strain is one of the factors that play a role. And it's also going via tenosynovitis. So if you have this heavy mechanical jobs, you have more tenosynovitis and you get more often the disease. But this is one of the risk factors. I think there are more. For ECPA negative disease, perhaps female hormonal factors play a role in progressing from CSA to RA. But I think there are many, RA is still a complex disease, so I think there should be many more factors that we don't know of. You can think about viruses or whatsoever. And on top of risk factors, I think it's also important to think about, pathophysiological processes or mechanisms. And actually, we don't know what is now the final hit that makes you progressing from a reversible stage with symptoms of subclinical inflammation, which is, I think, reversible, to the disease, a state of a chronic disease in irreversible joint inflammation. Actually, we don't know yet. And that's also so important because we want to do prevention trials. And we all try different drugs, and one of several of the hydroxychloroquine, but also methotrexate, abatacept. But we don't know exactly what is now the final hit or the final decisive process. And if we would know that, then we also would know what to target to get the best prevention. But I think we should still learn this, discover this.
Well, you've got a great resource, obviously, in both the Latin CSA cohort and the Dutch treat earlier trial to explore these. I'm sure that work is ongoing in your group. The research always has limitations. And you speak to that, I think, in your discussion some, but what are the key limitations that the audience should be aware of with this work?
Yeah, of course, there are always limitations. I will mention two. I think the first is, of course, validation. So where we use two Dutch data sets, but these are just the Dutch data sets. So it's always very good to go to other cohorts or data sets and to find out whether they're the same. So you always validate. As in science, it always is like that. Another thing, it's good to think about sustainability, because if we use the term resolution, it seems to be a permanent thing. And then you need, of course, very long-term follow-up to be sure that it's permanent resolved and there's nothing coming back. We had followed up to 2 years in our study. So we have this resolution for up to 2 years or something like that. But of course, you can always wonder what's happened thereafter. Does it come back? So we didn't see it happening so far, but you can always think about, is something permanent or is it just waxing and waning to some extent? So that is also good to realize.
Right. The long-term follow-up is always one of the limitations, right? Very hard to follow these patients forever, right? Especially with these patients who are sort of have a condition that gets better. Yeah.
Exactly. They disappear from clinic. Yeah.
Right. Yeah. Very, very difficult to study the people who do well. I think important to try, and it's great that you've been able to do this study and learn about those patients and describe that. I also, getting back, you alluded to, I sort of turned the story a little bit to focus on what makes people get worse again. The flip side is, what are the factors that sort of resolve it? Is it regulatory T cells, or what is the tolerance mechanism that somehow leads to this going away? And if we knew that, that would be a good treatment too, and to be able to recapitulate. So another reason to study this population. So I just wanted to give you an opportunity. There was an editorial to this article, and we mentioned him earlier, Dr. Kevin Dean at University of Colorado, who has done some important work also in studying these at-risk populations. And his critique and only issue, I think one issue, I think he thought it was an important study and appreciated the work, but raised the question about is there some issue with reproducibility of the definition of CSA resolution? Is it something that there's some subjectivity to some of the parts of the definition from either the rheumatologist or certainly the patient standpoint, um, that would make this hard to reproduce in clinical practice or other studies? So I just wondered if you had thoughts about that and what your response would be.
Yeah, nice question. So I think, to my understanding, this criticism is mostly dedicated to this rheumatologist-based expertise. So it could well be that Kevin's expertise is completely different from mine. I don't know exactly, but of course, this definition, or it could be a little bit subjective. But I think, therefore, and one of the results Sarah didn't completely allude to is that we also had another definition. So that's more patient-reported. They say, well, perhaps if you have pain resolution below 20 and morning stiffness below 20, then it resembles CSA resolution as by the rheumatologist much more. Because Sarah explained this also discordant, so people can have resolution of pain but still have morning stiffness, and as the doctors we think still there's some inflammation going on or something like that. But I think we also show that if you have both pain and morning stiffness disappearing or going below the 20 threshold, it's quite well. So I think if you would feel that rheumatologist-based expertise is not so easy to deal with, and I can understand this criticism, I would advocate to just combine these two patient-reported outcomes and say, well, if you have both no morning stiffness and no pain anymore, then I think two inflammatory components are really resolved. Then we can call this also resolution, and I think this is quite, reproducible in many settings actually. And it's clearly independent of the expertise of the rheumatologist. So actually, in future work, we may think it's easy to define a cutoff of both pain and morning stiffness moving below threshold of 20 millimeters. Yeah.
I was just thinking, how many patients have you had the opportunity after if they achieve that sort of resolution stage to repeat MRI and see if there's any remaining subclinical inflammation?
Yeah, so I think Sarah, I don't know exactly how many, but I think the majority of patients had repeated MRIs, and Sarah made a graph, and we can show that in this figure, and then you can see that patient that resolved obtained this resolution had really a decline in the level of subclinical inflammation, and in the end of the curve, you see a very low level of inflammation. I think that is approximately the level of inflammation that you can see in the other population, because if we all make MRIs, especially to what come a little bit older population, we see something on the scans, and I think the group that had resolution obtained a severity of inflammation or inflammatory-like symptoms, which is quite normal, actually. Yeah.
Mm-hmm. Yeah, you always see something on MRI, right?
Exactly. Especially the older
Yeah.
you get, the more you see. Yeah. Which
Yes,
is not
yes.
always pathology. So that's important to realize, actually.
It is, yeah. You can if you don't appreciate that, you can call a lot of people with RA when they don't have it.
Exactly.
No, very excellent. Thank you for that answer, and I think that makes good sense to me. What are your next steps to to move this field forward? Thinking about either understanding the at-risk stage or how these insights can help us with the holy grail of RA prevention.
Yes, exactly. I think this is the most crucial and nice question, actually. So I think the aim of the study we're talking about today was to study the definitions, and now that has been done, I think we can decide to use the definition of pain and morning stiffness below 20, as we just discussed. And now we are trying to proceed to study the processes that are related to this resolution of this risk stage. So especially if there was CSA and there was also subclinical inflammation on the MRI, and this all resolves, that's very interesting, I think. And what we're now doing is performing transcriptomics and proteomics studies on serial samples from the Treat Earlier trial from patients that achieved resolution and also patients that did not progress but had persistent arthralgia. And they were looking for the differences, actually. So ideally, this may reveal the processes that were crucial in achieving a spontaneous resolution. And that's interesting because these patients almost had RA because they had symptoms. They could have also have antibodies. They had inflammation at the MRI. And the symptoms and this inflammation disappear. So if we're going to understand the responsible mechanisms, this may also need to fuel our studies on targeted therapies, because these may be the mechanisms that we may want to promote with drugs that are aimed at disease prevention. So I think this is actually why I think this study is so relevant. So first we have to define the group, and then in this group we have to go to do the transcriptomics and the proteomics, and to see whether we can find differences that really differentiate these patients from those that do not achieve resolution, actually. Yeah. So this is ongoing work, but it's really ongoing. So
Yeah.
I have to wait for the results. Yeah.
I have to wait. Well, it's very exciting, all the, this resource that you created and those kind of approaches that you can use to better understand and dissect the mechanisms of progression in these at-risk patients. I thought of some additional question. The just to throw in, but getting synovial biopsy or some type of tissue biopsy, wouldn't that be fantastic if you could do one before when someone had symptoms and then after resolution? Do you have the access to that? I'm sure it's not easy to get people to biopsy a joint that feels fine at that point.
No, so Sarah has been involved in that. It is not so easy. So we mostly interested to get some very small tenosynovial biopsies from tenosynovitis, as we just discussed. It is the earliest inflammatory tissue, I think, and it is also most specific. So yeah, really interesting to see what's happening in this tissue and what differentiates patients that will not get the disease and will get the disease. It doesn't necessarily have to be repeated, but at least that we have two groups that we can compare.
Mm-hmm.
We have collected some, and we would like to do spatial transcriptomics on these tissues, but I agree, it is not so easy to get these samples in a high quantity.
Yes,
Yeah.
very difficult.
But I agree. So we're now looking at the transcriptomics that we discussed, and proteomics is indeed systemic based on blood, and tissue is even more challenging and perhaps even more promising as well. Yeah, yeah.
Mm-hmm. Yeah, yeah, very, very good. Well, any last thoughts or any last comments this morning? Actually, your afternoon. Very good. Well, again, Dr. Van der Helm-van and Dr. Khidir, thank you so much for joining us today. This has been a fantastic review of your study. And again, congratulations. I admire your work very much. Um, to our audience, we encourage you to read the article, Identifying Resolution of Clinically Suspect Arthralgia, a Step Toward Understanding Spontaneous Reversal of an At-Risk Stage of Rheumatoid Arthritis, which is available on our website, jrheum.org, and in the January print edition. Thank you for joining us. Stay tuned for next month's interview with another featured author. We welcome your comments on X or at jroom, or you can email us at manuscripts@jroom.com. Everyone have a great day.
Thank you.